Hi, my name is Roberto Martinez. I am a postgraduate Year 2 internal medicine resident at Tecnológico de Monterrey, Escuela de Medicina y Ciencias de la Salud in Monterrey, Mexico. Today we're going to discuss an approach for the early ruling of an atypical cryptic sepsis presentation using a three-step process. First, the application of hemoglobin-adjusted Baker criteria, followed by the application of survival sepsis campaign criteria to confirm sepsis operative definition, and lastly, reverse et al. Criteria to outline our patient's sepsis evolutive stage. The ATP was admitted on August 1st of 2020, diagnosed with COVID-19 type 2 diabetes mellitus, complicated with chronic kidney disease, category 2, polyneuropathy and retinopathy, as well as dyslipidemia and hypertension. On admission, he showed signs of respiratory distress with 31 cycles per minute, 74% on pulse oximetry on free air, but he was non-febrile and otherwise stable. He received high-flow nasal cannula at 60 liters per minute and 100% of FiO2, plus our hospital anti-COVID pharmacological scheme that included azithromycin, ceftriaxone, and dexamethasone. By August 7th, he was under low oxygen requirements, had mild delirium, and venous lactate of 2.1. His SOFA score remained in 2 across the days. He was put on a PICC line and started baricitinib 2 milligrams orally daily. By August 12th, his vitals were stable, but he had dry mucoses, lower left limb pain, graded as 9 out of 10, and he also fell on his left side once during an episode of delirium. Thereafter, he developed a left lower back ecchymosis as shown in figure 1. We still wanted to rule out sepsis and implemented the Baker criteria on August 10th. Then his remeasured lactate was on 2.2. Fick method showed him having a cardiac output of 8.7, an arterial venous difference in 1.47, an hemoglobin in 9.3, a respiratory quotient proxy of 4.5, and a venous to arterial PCO difference in 6. Thus, we evidence a strong likelihood for systemic anaerobic metabolism not entirely explained by his current degree of anemia. We started survival sepsis campaign bundles as he was now on a delta SOFA of +3. His third measured lactate was now at 2.8. Catheters were changed, urine, blood, and sputum were cultured. He was started on Harman at 30 milliliters per kilogram, and he was suspended of baricitinib. On August 12th, he developed leukocytosis and anemia, and his procalcitonin was in 0.27. We swapped ceftriaxone for meropenem 1 gram thrice per day and added linezolid 600 milligrams twice per day. He was also transfused with 1 blood unit, and we suspended enoxaparin. By August 16th, his pulse oximetry worsened to 88% on free air, but the rest of the vitals were non-remarkable. An IV contrast abdominal CT was suggestive of an superinfected psoas hemorrhage as shown in figure 2, and a urine culture was positive for an SBL Klebsiella pneumonia. An additional blood culture showed Streptococcus parasanguinis. Based on reverse criteria of a lactate above 2, a central venous oxygen saturation of 45%, and a normal mean arterial pressure, we were able to classify our case as an stage A cryptic septic presentation. We believe this was an effective course of actions for the early ruling of an atypical cryptic septic presentation in a patient under difficult to diagnose confounding conditions.